Hello everyone, I am Dr. Anup Hazare from MCure. I welcome you on behalf of 61st AICOG 2018 from Bhubaneswar. You are watching this interview live on therightdoctors.com. Today with me is Dr. Queen Aditya. Ma'am is from AMRI Hospital, Kolkata. So ma'am has chosen a topic, very right topic for Indian, if you look at the Indian scenario, that is the iron requirement and supplementation in pregnancy. So ma'am, do you think all the women in India today require iron supplementation when they are planning for a pregnancy?
In India, India is actually endemic for anemia. Almost every woman is anemic across the strata, and the lower strata obviously, more so with hookworm infestation and all kinds of diseases, tuberculosis and all that. So in pregnancy there is a physiological anemia which all of us know, but that per se does not require so much of iron because that is a normoblastic normocytic anemia. But the thing is that along with that, with the growing mass of the hemoglobin, with the placenta, the fetus, all of that growing will require an extra 1 gram of iron during pregnancy, and that needs a supplementation. So every woman in India roughly requires some kind of iron supplementation, and because of rising trends of anemia, in spite of all the measures that are being taken, most of the women will require higher doses.
Right, ma'am. Now, ma'am, that said, ma'am, which one formulation of iron would you prefer? If it is a oral, which one you prefer? And if it is an IV or injectable preparation, which one you prefer?
Yes, exactly. Now, ideally, I would want to give IV to everyone just to ensure that it's being taken, because compliance is a very big issue, but that is not practicable, and people are going to run away at the very thought of it. So we have to start with oral iron. Now, oral iron comes in all kinds of formulations, and with so much available right from time immemorial, ferrous sulfate, ferrous fumarate, and all of those are there. And nowadays there is heme iron, and the whole range is there. But if we have to look at bioavailability, then the highest bioavailability will be with ferrous ascorbate. So I personally use that, and I would recommend the same.
Right, ma'am. No, ma'am, amongst the IV preparation, so many formulations are there, and today we see that a lot of people are debating on the role of FCM, ma'am. This is a new molecule.
Yes.
How do you see this molecule, ma'am?
Earlier the IM formulations were also there, but because of a lot of problems, first of all multiple injections, then painful injections, and then staining at the site, compliance, all of these, then people are living in far off villages have to keep coming and going for the same. So that's why it's not very practicable, and nowadays with the IV formulations available, we don't go for that anymore. IV iron sucrose is something which I personally prefer during pregnancy only because it's approved. Okay. Large and wide, it's approved. That's why I go for iron sucrose during pregnancy. But in postpartum or any other situation like menorrhagia causing anemia or preoperative, in those kind of situations, I go for FCM without any doubt.
Right. So what are the advantages what this molecule FCM carries over other molecules?
FCM is a robust iron,
Okay.
Carboxy maltose, so its stability is very high. It does not require any test dose, and the biggest advantage is that a huge amount can be given in one sitting. So for that, up till 1000 milligrams can be given in one sitting, and whereas in iron sucrose we can give a maximum of 200 milligrams in a single sitting, and maximum 3 times a week. So in a week we can give a maximum of 600, and whereas 3 sittings are required, and here in a week we can give 1000 only in a single sitting, and it takes hardly 15 minutes for that 1000 milligrams to be given, and that's why it is very patient friendly, and so less amount of disposables are required, less amount of traveling to the healthcare facility, and less physician time, less patient time. So in every respect I would prefer FCM, but till now it has not received approval from all the august bodies during pregnancy. So
yes.
Currently I am refraining. Personally, I know a lot of people who are going for it, and a lot of studies are also going on, but as long as it is not actually approved, I will withhold it during pregnancy. But immediate post, even in most of the cases, immediate after both post delivery, I am giving a lot of women before discharging them also. When I see they are still anemic and I don't know whether they'll go home and comply, so I usually am trying to give them FCM after their delivery as well.
Yes, ma'am. Very rightly you have said, ma'am. If suppose the benefits are outweighing the risk, then we can go ahead with this molecule, especially in the second and the third trimester.
Yes.
Ma'am, what are the key message you want to give to our audience or the upcoming gynecologists, PG students?
Yes, now there's a lot of misconception about the iron intake. A lot of people say have iron after food, but there is a gross problem in absorption. So we should know that iron ideally should be taken in between 2 meals. So what I usually do is I tell the patients, you take your breakfast roughly around 8:39 and have your lunch at 1, so around 11 a.m. you go for the iron. And ideally it can also be taken in empty stomach, but because there can be a lot of gastric irritation, that's why we do not say so. I think 11 a.m. is a good solution. It is ideally taken with lime juice or something like that, but when it's already there in an ascorbate form, we are not worried about that. It is better to avoid tea, coffee, tannins, those kind of things, because they can hamper the absorption. And that is why this is something that a lot of people don't know. A lot of people say have it after lunch or have it after dinner, and then the bioavailability goes really down, the absorption goes really down. So that is something that I would like to put forth. The other thing is that we, as I said, I would ideally go for IV iron just to ensure that it is being taken, but that cannot be done. That's not practicable either. So we go for the oral form, but we have to monitor the patient throughout whether there is the hemoglobin is rising. If it is still very low, then at 32 to 33 weeks of pregnancy, I think it's time we take a call, because for reticulocytosis and proper erythropoiesis, at least 3 weeks is required. So roughly 32-33 weeks, if we take a call, whether we go for IV or oral or whatever, then it will take 3 weeks. So that will become 36-37 weeks. And by that time, by the time she is about to deliver, we should ensure that her hemoglobin level is good enough. And that is why at 32-33 weeks, we should take a final call whether to go for IV iron. And if someone feels FCM is suitable, they can go for it. Personally, till now, I am not doing so. In this particular stage, I go for iron sucrose, and whatever is the remaining requirement is I go postpartum.
Thank you, ma'am. Thanks for sharing your opinions. It
Thank
was
you
a
so
pleasure
much.
to have you here, ma'am.
Oh, thank you so
Looking
much.
forward
Pleasure
to
was all
connect
mine.
with again, ma'am. Thank you, ma'am.